everybody. Thank you so much for coming today. Really excited to be here. As you will probably gather from this presentation, I get very excited. It's an area of passion for me. I love talking about sexual health, especially sexual health around illness, around cancer, around tumor diagnoses. So very excited to be talking to you here today about sexuality, intimacy, and dating after a brain tumor diagnosis. And Todd already gave you a bit of an overview of where I'm coming from. That was great. So yes, I am a registered social worker in British Columbia. I'm currently in Vancouver at our Vancouver office of InspireHealth. And I'm going to give you a little bit of information about our organization in just a moment. So I'll get to that. But I'm both a counselor and, as Todd mentioned, have a history as a sexual health consultant and sexual health counselor, specifically in cancer care in Alberta. Yeah, so really excited to talk about a lot of different things today. I'm going to start with an introduction to my organization. I'm going to cover some foundation information, some information about the ways that a tumor and or a cancer diagnosis can impact sexual well-being. We're also going to talk about physical impacts and interventions specific to vaginal and vulvar changes, then specific to erectile function changes, and then changes that happen for all bodies. And we're also going to talk about emotional and relational impacts. So lots of information, probably more than maybe you even want, but hopefully everyone takes a piece away. Okay, and so my presentation, I'll just say, is going to be probably somewhere around an hour today, depending on how quick I talk or how many questions you all have. So, okay, and please do, as again, as Todd already mentioned, go ahead and put your questions in, and Todd will either give me a heads up or I'll notice them and get to them as quickly as I can. All right, so to start off, as I mentioned, with some information about InspireHealth, which is the organization I work for, and we are a supportive cancer care organization. So InspireHealth is a not-for-profit founded in 1997 with a vision about really what supportive cancer care could be. We are partially funded by the Ministry of Health and also rely on donations for the full offering of our classes and programs, but all of our services are fully free of charge, no cost at all, and no referral required. So people can actually register right online and sign up for classes there. And similar to many organizations, we are all online at the moment. So we do have our 3 sites across Vancouver, across BC and Vancouver, Victoria, and Kelowna, and a very quickly burgeoning, growing online community, as many of you, I'm sure, are part of a few now. So I'm going to go over in a moment some of the classes and things we offer, just to give you an idea. But we support people with cancer or those at high genetic risk of cancer, and really take an evidence-based approach to supporting quality of life, whatever that means to the people coming, to each person, because of course that might mean something very different to each of us. And I do want to acknowledge that for all of the folks watching today, I know not everybody has a cancer diagnosis. So unfortunately, our organization may not be accessible to everybody watching today. But I really hope that this presentation, at least from us, will give everyone something to take away, something helpful or interesting for them. And for those of you who do fall within that mandate that we have, just wanting to let you know what we offer in case you are interested in accessing. So we have lots of people on our clinical teams. We have supportive care physicians, which are GPs, they're medical doctors, not meant to replace your own GP or your oncologist, but to be an extra set of ears to support with things like decision-making, stress management, emotional well-being, all of those pieces. We have clinical counselors that provide counseling for clients in one-on-one appointments, and also run some group classes and educational workshops, and some of our doctors do that as well. And then we have exercise therapists, which, as you can probably imagine, help with movement and activity plans throughout recovery and at all stages. So they run group classes and one-on-one appointments. And we also have registered dietitians, so that, again, one-on-one appointments, as well as lots of group classes, cooking classes that help with nutrition and cancer, or making food choices, all of those kinds of pieces. All right. So this is my last slide about InspireHealth, but just to give a little bit more information about the approach. So we work from really a person-centered approach to add to other medical support or other supports that people might be getting. So while treatments generally target the cancer or the tumor, if that's part of the cancer, we hope to support by also targeting well, the rest of the human. So that all the pieces that feel important to each of us. So it might be nutrition, it might be exercise, it might be emotional or spiritual well-being, stress management, many, many things. And it might be sexual health, like we're here talking about today. So again, all of those areas of well-being and quality of life. Yeah, okay. So that's my introduction to us, and now to actually dive into that piece about sexual health. So this is just a quick acknowledgement that, of course, as we dive into this conversation, we all have very different values, experiences, and beliefs when it comes to sex and when it comes to sexuality. And we all have different comfort levels, and that's okay. Noticing where we feel comfort and discomfort, what feels important to us or not, can be helpful as we figure out what changes we might want to make or not make, what might be helpful for us, and essentially what we want. So I want to be clear that there's absolutely no intention here today to challenge or change values or beliefs, just support to notice them. And my motto, or the motto that perhaps you can take in with you, is take what fits, leave the rest. So hopefully we each get one or two things that feel helpful and interesting, and anything that is not a fit for us, just leave it here in the room. Yeah. And as we talk about sexuality, again, that might mean very different things to different people here today. So we all have different understanding and experience of sexuality. And so each of us, if we were to make a little word mind map like this, would probably have different words or ideas or feelings included under our umbrella of sex and sexuality. And again, that's okay. It's actually great. So go in with whatever that means for you, and we'll go from there. Okay. And similar vein to the last two slides, while we all have different understandings of sexuality, we all have different relationships to sex and sexuality, we also all have different experiences and wants. So some of the people here today or watching in the future may already be in sexual and or romantic relationships, may be curious about or wanting to enter a new or our first relationship, or may not be interested in romantic or sexual relationships at all. We may be currently engaging in sexual activity with others or with ourselves, may be interested in engaging in sexual activity in the future or now, or may not be interested right now or ever. And again, all of this is okay, and all of this is normal. So wherever you're coming in from, I'm happy to have you here today. And again, take what fits, leave the rest. So I'm gonna, before I share a bunch of information, I'm hoping that some of you might be willing to share a little bit of information about your own experiences with me. So I have a few polls that Todd has so kindly typed in on my behalf to share with all of you. And the intention of these questions is just to get a bit of information of where everyone's coming in from. Completely optional, also completely anonymous if you do choose to join in. And the questions are how a brain tumor diagnosis has impacted sexual health, maybe a lot, maybe a little, maybe not at all. Whether our healthcare teams have talked to us about sexual health and well-being. Again, maybe a lot, maybe a little, maybe not at all. And when it comes to sexuality, intimacy, and dating after a brain tumor diagnosis, how are you with the sexual health right now? Maybe you have no questions or concerns. You're just here to see what it's all about. That's great. Maybe you have a couple questions. Maybe you have endless questions and concerns, lots of them, all fine, but just getting a sense of where we all are in the room right now. So Todd, if you have it up and ready, perhaps
Sure.
you can throw that in.
Yeah.
Awesome, and I'll just give everyone a moment to actually do those if they're willing or interested.
I hope everybody can see the poll all right. I can see it on my end. Yes, we're getting some answers come through.
Perfect. Yeah.
Yeah, take your time. Yeah, thanks
Yeah.
everybody. Yeah, that's getting quite a bit of participation. This is
Awesome.
a good participative group. Thank you so much.
Yes, much appreciated. Yeah, no problem if you're not wanting to answer.
Yeah, and that's okay. I love that analogy too, Tess. If the shoe doesn't fit, that's okay. Treat this like a shoe store. Take what works and leave the rest on the shelf. And that's okay.
Absolutely. Yeah. Yeah, I like that. The shoe store.
Yeah.
Okay.
What do you want me to end it now? We got, Jesus, pretty much everybody. A few more minutes?
Yeah. I'll give them maybe just one more second in case anyone's just finishing up now, and then yeah, I can actually see them up here too. So
okay. Oh, so you can end the poll as well. All right.
Oh yeah, I can.
Yeah, all right. I'll
Thank
leave
you.
that up
Didn't
with you.
even see that.
Yeah. So once you end
Perfect.
the poll, I believe it'll just share the responses with
Oh,
the people, but it will not give names or any identifying information. Yeah.
Perfect. That's what we're hoping for. Okay,
Yeah.
ending the poll now. Let's see if it'll.
Yeah.
Can you see these results that I've
yep, I can see
I've shared?
Yeah.
Perfect. Okay. So yeah, hopefully everyone can see those. Let's take a look at what's happening. So in terms of how our sexual health has been impacted by a diagnosis, if it has, it looks like we have most people, we have 6 out of 9 at somewhat, and then we have a couple people at a lot, and someone at not at all. So great, across the board, we've got all kinds of experiences. Oh, we've got a little. Oh, it's the same. Oh, sorry. It's showing up in a bit of a different way just below. Apologies. It's just the second question, but similar questions, same answers. Again, mostly at somewhat, some at a lot, and some at not at all. And then question 3, how our healthcare team has talked to us about sexual health and well-being. Yeah, unfortunately, I'm not surprised to see this, but it looks like we have one person who was talked to a lot. That's wonderful. I'm so glad to hear that experience was had by even one person, someone somewhat, and most people not at all. Yeah. And when it comes to sexuality, intimacy, and dating, I have so a few people at no questions at all, and quite a few at a few questions. Okay, awesome. Well, thank you so much for sharing, everyone. That's so great to get a sense of where we're all at in this. So I'll just close that. So, I mean, one thing this does show us is wherever you are, you're not alone. There's people who are having that same experience as you, people across the board for all of these questions. And it also brings me to my next slide, which is a little bit about sexual health being a gap for many people in their healthcare experience. So similar to this poll here, many people don't get talked to by their healthcare teams about sexual health, but have had impacts and do have questions. So your responses certainly line up with what I've heard from many other people in the past as well. So that sexual health for many people is an unmet need. So the research you see on the slide here is not specific to brain tumors or to head and neck cancers. In fact, as I'm sure I'm not going to shock anyone here today, it's quite hard to find information about the sexual health experiences or concerns of those who have had a brain tumor diagnosis. It's something that clearly does not have enough information or research or attention around it. So most of the research around tumors and cancer care is for folks with cancer diagnoses in the pelvic area or in the breast area, is where most of that sexual health conversation happens. But it is my belief that all diagnoses, all experiences of cancer or tumors do have an impact on sexual health. So, but what you can see from this study from 2012 was that 78% of people would have thought that information was really important. But you can see the list below at how many people actually received that information. So 79% of prostate patients, so that's a bit higher than the rest, but 39% of colorectal, 29% of breast, 23% of lung. So a big gap there in many of those groups. And from our own poll, we can perhaps come to the conclusion or get some information that for folks out there with brain tumors or with cancers also have that experience of perhaps wanting more information than what's being offered. So let's try to fill that gap a little bit today. That's the intention. Yes. Oh, and I see some comments there. It's a funny observation since many people say the brain is the largest sexual organ of the body. Absolutely. Yeah. It really, yeah. I say that all the time. Thanks for sharing that. There is some irony there for sure. Okay. So impacts of treatment. Treatment looks, of course, very different for different people. So some of you may have had multiple treatments, some of you may have had none of these treatments. And again, my belief that any diagnosis or treatment has an impact. So in this presentation today, I'm going to share a lot of information, like probably more than each of you individually wants. And we're going to start with what I mentioned at the beginning, some physical impacts on vaginas and vulvas, then for erectile function, then for all bodies. And we're going to talk about desire and sensation, relationships, dating, communication. And my hope is that each of you leave with at least one piece of information that you find helpful. And my apologies, you're probably going to have to sit through some information that does not feel relevant at all, but hopefully it's relevant for somebody else in the room. Because I don't know what treatments or diagnoses, primary or secondary, that you each might have experienced, I'm basically going to cover all the bases. But to start with a brief explanation of how treatments can be impactful, chemotherapy, as I'm sure you're all aware, can cause nausea, pain, fatigue that might impact sexual health. It also might impact things like ovarian function. So our ovaries are where the majority of our estrogen is produced. So when our ovaries are impacted or estrogen is impacted, that plays a big role in vaginal and vulvar health. So some people may be experiencing what you see at the top row on the right there in the orange, vaginal atrophy, which is a drying and a thinning of the vaginal tissues. They might be experiencing dryness or stenosis, which is a narrowing or a shortening of the vaginal canal, a sense of tightness. Radiation can cause scar tissue, changes to nerve function, pain, wherever it's directed, anywhere in the body. For some of us, that might be in the pelvic area of the genitals, or we might be experiencing those impacts elsewhere, all over our bodies. Surgery, of course, can have a ton of impacts. Wherever our body experiences surgical intervention, there can be changes to blood flow, to nerve function, just to general function of that area of the body or where it's connected. Stem cell transplants also can have big impacts on well-being and sometimes can be accompanied by radiotherapy or by chemo. And hormonal therapies too, if any of you have ever experienced this, of course, impact our hormones. So that can have a big impact on our sexual well-being. And lastly, to acknowledge another approach, the watch and wait approach, as it's sometimes called, that too can have really big impacts. That comes with huge anxiety for many people, changes to emotional well-being, and all of that is tied to our sexual health as well. So that's a really, really general description. This is just a short list of what could be a very long list of the many ways that we might find ourselves being impacted by our treatment or by the diagnosis itself. So whether that's physical well-being, mental health, emotional health, or relational well-being. And I'm going to dive quite a bit deeper into some of these things. And we're going to start again with that idea of vaginal and vulvar health. So there are a lot of different ways that our vaginal and vulvar health might be impacted. Could be that chemotherapy impacted our ovaries or estrogen production. Our ovaries or our vagina or vulva may have been impacted directly by things like surgery or radiation. As well, we might be experiencing menopausal symptoms as a result of any of this. And that might be things like what I mentioned, that vaginal atrophy, that dryness, that tightness. So we're going to go through some interventions that we might use to address if these are happening for us. And the last four there that you see, I'm going to cover later in interventions for all bodies. So to start, non-hormonal vaginal moisturizers. Perhaps you've heard of these. If you haven't, they are exactly what they sound like. They are moisturizers we apply to the vagina or the vulva that do not have any hormones in them. So if this is new to you, just like we can moisturize our arms and our legs, we can moisturize our vaginal and our vulvar tissues, which unfortunately not a lot of people know, which is too bad because it's a pretty good, simple solution to what can be really challenging symptoms. So this is something that might become really important if we're experiencing dryness. Couple brands that are just up there among many, many more. These are just three. So you can see up there, I have Gynatrof and Repagyne and Replens, but there again are far more. And they come in different forms. So some are tablets, some are creams or gels. You can see the Repagyne in the middle there is a little tablet that gets inserted into the vagina. There are also applicators. So it's a tube or a cream that you insert some into an applicator and insert that way. And so you can see the Replens on the right there is one of those, and the Gynatrof on the left, I believe, is also one of those. And yeah, sorry, let me just keep going. Lost my train of thought for a second, but so these can be inserted with a finger or with an applicator. Many of them come with an applicator. And we probably want to be applying these to both the vaginal and the vulvar tissues since they can both be quite dry. And we're going to want to apply them before bed, and purely for gravity reasons, because things are going to stay in if we're lying down. A few notes that the box on these is probably going to say use them 2 to 3 times a week, but this might not be enough to get the benefits. So especially for folks who have been through treatment where they're having these experiences, because it's not like gradual menopause that some people might experience. It can sometimes happen much quicker than that and be quite abrupt for the body. So sometimes we need a bit more to get things started. So rather than 2 to 3 times a week, it might work to do this every day for the first month and then reduce to less often if we choose to do that down the line. Yeah, so a note that it also can take up to 3 months to actually see the benefit. So if you've been using these for a few weeks and you're thinking, oh, it's not working yet, it can be really frustrating, but just know that that might still happen for you. So it takes a little bit of patience. And if you don't want to use these moisturizers, or if they're too pricey, because affordability can be a big problem with these, they do certainly add up in cost. It is also an option to try a plant-based moisturizer. So things like coconut oil, vitamin E oil, even olive oil. These can be used internally or externally for dry tissues. And we're also going to talk about these when we talk about lubricants. Because they are oil-based, they do stick around in the body longer. So there is a potential increased risk of infection with that. But with that said, many people swear by plant-based oils. I've heard so many people talk to me about using coconut oil that just really love it. But if you're not sure, or perhaps if you're someone who's prone to UTIs or infections, check in with your doctor for sure. Check in about this, and they might have something to say. I can see, sorry, I just noticed something in the chat. I'd appreciate to hear how hypothyroidism affects sex drive. That's a really good question. And in transparency, that's not actually something I know a whole lot about. I haven't worked with a lot of folks experiencing hypothyroidism. I certainly have people tell me that their challenges with their thyroid do strongly, they have noticed a change in sex desire with that. And I'm going to talk quite a bit about desire at the end, more around how we manage when we do notice changes. But in terms of the direct relationship between those, apologies, that's not something I actually know a whole lot about. But it's a good note, because that's something, as you say it, I'd very much like to learn more about. But I will talk about desire for sure. We're going to have a big conversation about that at the end after I fill you up with a whole lot of other facts. Okay. As well as moisturizers, just a quick note on hormone-based interventions, because they might be an option for some people. So hormone replacement therapy is when our hormones enter our body, maybe orally or perhaps through a patch on the skin. And this is something you talk to your doctor about if you're wondering about options. They get prescribed, and they might not be an option for everyone. So it's worth chatting through with your doctor if you are curious. Same thing, topical hormone therapy. So this is creams or tablets, much like the non-hormonal moisturizers, but with hormones in them. And you apply them topically to the vagina or the vulva. Some folks find these work really well for them. And again, may not be an option for everyone because of those hormones in them. So would need to be prescribed by a doctor, and something to ask about if you're curious. Okay, I know I'm blowing through information here, throwing a ton at you. So again, throw those questions in the chat if they come up. But if not, I'm going to carry on full steam ahead. All right, so vaginal inserts or dilators. Again, perhaps something you've seen, heard of, maybe even had recommended to you, or maybe the first time you're coming across them. We don't talk about them very much. I know for me, it's not something I knew much about until I started learning about the world of sexual health, but they're really common. They're really common. So I hope to talk more about them just as we go and make sure everyone knows what's out there. You can see a photo on the right there if you're wondering what I'm saying when I say a dilator. So they are long cylindrical objects that are used to open and stretch the tissues of the vagina. They often get recommended after pelvic radiotherapy to help prevent scar tissue. And some of you may not have had radiation ever, or specific to the pelvic area, but that doesn't mean these might not be helpful for you. Many people tell me they find them really helpful for those menopausal symptoms too, for anyone who might be experiencing a sense of tightness or even just an uncertainty about what the vagina can comfortably accommodate. Sometimes we might be a bit worried about things not being comfortable, and it might be helpful to trial that and see what we can comfortably accommodate when we have full control and when we're in a situation where we can really just experiment with ourselves and see what works and what doesn't. So for all of those reasons, dilators might be helpful. And it also might not just be for sexual activity. So even if we're someone who doesn't ever want to have insertion as a part of our sexual activity, we might still be interested in this if we're somebody who, for example, receives pelvic exams for our health. So we might just want to use these to get to a place where it's comfortable for us to have a pelvic exam and have a speculum inserted. So lots of reasons we might engage with this. But when we do, it would usually be 2 to 3 times a week. We'd start with the smallest size that provides a bit of resistance without causing pain or discomfort. And again, we'd be continuing with that size about 2 to 3 times a week until we feel a little less resistance, a little more space, and then we'd move up a size. And we keep doing that until we get to our goal size. And again, that goal size might be very different for different people. It might be what's needed to comfortably receive a pelvic exam, to engage in sort of sexual activity with a finger or a toy or a penis. But as we go, we don't want to be feeling pain. So if you were to insert a dilator or anything else, we don't want people to be feeling pain. So if you are, try a smaller size, insert less deeply, ask your medical provider if you're not sure. Some people think of dilation like physiotherapy, stretching the vaginal tissues the same way we might stretch all the other muscles in our body. Some people think about it like pleasure, and they want to incorporate vibration. So it can be done on our own, it can be done with a partner. You're going to hear me, I'm going to sound like a broken record. I'm going to say this so many times, but whatever works for you, however it works for you to engage with this is great. So the ones up on the board there, you can see up on the board, up on my slide, I'm stuck as if I'm presenting in person, are called fuse dilators. So they're quite flexible. If you were to hold one, you'd see you can actually bend them, but there are others that are made of hard plastic if you prefer. There's ones with vibration built in. You could also use a finger. You could use a toy. Anything that provides the resistance you need is great. And just to say really quickly how it works, you'd find a comfortable position, perhaps somewhere with some privacy. For some people, it's lying on their back with their knees up is the position that works. Slowly inserting the dilator into the vagina with lots of lubricant, a liberal amount of lubricant. And you're going to stop inserting when you feel resistance and hold it there. So we want that resistance because that's what gives the stretch, but we don't want to feel pain or too much discomfort. And we're going to keep it in for 10 to 15 minutes, just moving it around really gently, really slowly. And when we're done, we can wash them off with warm soapy water. And I don't want you to think you have to memorize this. Number one, this will be recorded. And number two, I have some resources at the end that you can refer to if you have questions or if you're interested.
I do have a question, Tess. Where do you find these products?
Yeah, very good question. So you can find them in a number of places. Online, of course, there's a number of places. So yeah, of course, where we find
everything's online, yeah.
So the Fuse ones that I just mentioned, F-U-Z-E, they have a website online that has them. There's one called Soul Source, like spelt just like it sounds, that has a few different dilators. Dr. Berman's dilator is a type, it's a hard plastic with vibration built in. So lots of places like that. I think some of them are probably, I mean, I'm sure they're on Amazon, like what isn't on Amazon? But you also might be able to find them if you have a local sex positive store. They often carry things like dilators as well. So you might be able to find them in person there.
Awesome.
Yeah.
Great. Thank you.
Absolutely. Perfect. Okay. Yeah, so interventions for changes in erectile function, change in direction just a little bit. So there's lots of reasons why we might experience changes in erectile function. Many different treatments or experiences could impact this. Could be radiation to the pelvic area, could be medications that we're taking, could be surgical interventions, might be related to the experience of receiving a diagnosis or to stress, anxiety, fatigue, all of these things. And I'm going to share a number of different interventions. We're going to start with some of these medical interventions that people might try. And then you can see the ones at the bottom there, like the physiotherapy and the exploring pleasure, we're going to talk about in the all bodies portion of this presentation. So I'm going to share a little bit of information about each one that one or more may be helpful or interesting to you. And it's just a brief overview. So if you have questions, talk to your healthcare team. Many of these require physician's involvement anyways. So just to give you a bit of a buffet, if you will, of all the things that you might be curious about, and then you pick and choose the information that might be interesting for you and go talk to your healthcare team a bit more to get more depth. So to start, the PDE5 inhibitors, we probably have heard the word Viagra at some point in our lives. So that is a PDE5 inhibitor. It's a type of medication. And what these essentially do is help get more blood to the penis to facilitate an erection. So we take them before any activity where we would want an erection. And there's a number of different drugs available in Canada. Again, they do require a prescription. So if you think it might be helpful or interesting for you, chat with your doctor about this. Penile injections, which I'll just start by saying, I know many people, I say penile injections and people in the room are like, ooh, because it sounds a bit terrifying. I promise they're not as scary as they sound. They're very, very small needles that get injected directly into the shaft of the penis. And many people say they can do it with very minimal or no discomfort because it is quite small and yeah, so those drugs, the injections can work for some people, even if a PDE5 inhibitor hasn't worked for you or isn't an option for you. So it can be another option that can be quite effective for many people. Again, they do require a prescription, so something to chat with a doctor about. A vacuum erection device. If you're wondering, if I pulled this slide up and you were like, what on earth is in that photo on the right? This is where I explain to you what that photo is. So this is a vacuum erection device. It is an external device that you insert over the penis and use a gel to create a seal, like an air seal. And then you pump the air out of the cylinder and that pressure pulls blood into the penis, creating an erection. So some people might use this almost like exercise, like rehabilitation to keep function and so they might make an erection and then let it release and then make an erection and let it release, almost like you're doing reps at the gym or something like that. But they can also be used to create an erection for sexual activity or for any reason we might want an erection. So if we're doing that, we would pump the air out, we'd create an erection, and then we'd pull a ring over the base of the penis to hold the blood in there and to maintain that erection. And we can maintain that for up to 30 minutes before we would need to remove the ring. So it can be a really good option for anyone who either the medications aren't an option or for people who just don't want to take medications if that's something that you're not interested in.
Yeah, there could also be side effects too with that medication, isn't it, Tess? If you're taking specific medications, you probably want to check with your pharmacist as well, right? Just to be sure
absolutely.
There isn't. Okay.
Yeah. If you were to take either penile injections or PDE5 inhibitors, that's why they require prescriptions.
Okay.
Because thanks for saying that, Todd, because that's absolutely why I say it's something you would need to talk with a doctor about, because they would look at the other medications you're taking.
Okay.
Other health conditions that might be a problem with those medications, and they're not an option for everyone. So if you have something else going on in your body that might have a negative effect with those medications, certainly you might not want to take them. So you might not want to for your own reasons, or your doctor might say, I don't think this is a good idea. And in that case, certainly, perhaps the vacuum erection device is a fit for you. So that's something, and many doctors know about these too. So certainly something you could also chat with your physician about, even though you don't need a prescription to buy one of these, but you could if you wanted more information. So a belted prosthesis, what I mean by that is a phallic or a penis-shaped object, sometimes we call them dildos, that get inserted into a harness that we wear around our waist. If the person wearing it has a penis, there can be a hole below that we insert a flaccid penis into where it can be stimulated at the same time. So that is something that we might use to create an erection, or we might choose to wear it otherwise just for part of our activity or our enjoyment. So those can also be bought online or at sex positive stores. Important to note, many people don't know that we can, if we're choosing and trying to achieve orgasm, we can have orgasms by stimulating a flaccid penis. So an erection is not needed for an orgasm. Many people can have a lot of pleasure even without that. Penile implants, I'll mention very quickly. So they are a surgical device that gets inserted, actually surgically implanted, non-reversible, likely only recommended if there are permanent changes to erectile function that can't be helped with any of these other interventions. And as you can imagine, that would be lots of conversations with many different doctors. So yeah, part of the reason I go through these a bit more briefly is because they do require a lot of physician involvement. So you'd likely be going to a doctor to talk in a lot more detail about all of these anyways. Yeah, so as you can see, I also include information down there, exploring pleasure, non-insertive sex, activity that doesn't require a firm erection. And we're going to talk about that in a little bit. Yeah. So again, at the end, I'm going to have a bit more information for you of where you might go to take a look at these things in more detail if you're interested. And you can ask your medical team, but we're going to talk about exploring different kinds of sexuality, pelvic floor physio, and these can all be ways to support ourselves and our sexual well-being as well when we're experiencing erectile function changes. Okay. So I'm going to move over to interventions for all bodies. And I love these ones. These are where I have so much fun talking about these. We're going to talk about, these might be helpful for vaginal dryness, changes in erectile function, changes in sensation, for engaging with pleasure, avoiding pain, responding to changes in desire, relational changes, all kinds of things. So we're going to talk about lubricants and pelvic floor physiotherapy, vibration and massage, different tools and toys, and exploring pleasure and sensation. And I'm going to start with lubrication. Okay. And if you are thinking to yourself, you know, you're spacing out right now going, I know about KY jelly. I'm good to go. I got the lubricants down. I'm about to share a whole new world of information with you, because let me tell you, the world has come a very long way since the early days of KY jelly. There is a lot more out there when it comes to lubricants. So if you go into a pharmacy, you're probably going to find water-based lubricants there. That's what's mostly there. You're probably going to see KY jelly, and there's nothing wrong with it. Like if that's what you like and that's what works for you, that's awesome. But let me tell you, there are many other options if you've tried it and you're like, oh, this is not my favorite. So some of these though can be a bit harder to find. You might need to go online or to a local sex positive store. Good Clean Love, the green bottle on there, is an organic water-based option. Other brands on there, Pink Gun Oil, Sliquid, come in water-based, come in silicone-based, or hybrid, which is a mix of the two. And I'm going to talk about this, right now. Okay, lubricants. You're about to see me get so excited. I love talking about lubricants. I just think this is the easiest intervention that I would recommend for pretty much all people for all reasons. And I think it can just make so many of our sexual encounters with ourselves or with others so much more enjoyable and wonderful. So I can't recommend them enough. So water-based lubricants, super easy to find, really affordable, safe with all sex toy materials, and barrier contraception methods. The negative side is if you were to put some on your hand right now and move it around, you'd notice it does dry out quickly because it's water-based, it dehydrates, and it gets almost like sticky or tacky. So we have to keep reapplying it. Silicone lubricants are longer lasting. They are not water soluble, so you can use them in the shower if you choose to. Compatible with barrier methods of contraception. The challenge is harder to find. They can be more expensive. And for a chemistry reason that I cannot explain to you with my minimal chemistry knowledge, silicone lubricants cannot be put on silicone-based objects. So like if you had a silicone dilator or a silicone toy, the silicone lubricant can degrade the other silicone. Again, I can't tell you why, but I can tell you that that's one of the things that happens. One of the another option is oil-based lubricants. So those would be, and to be very clear, I mean plant-based oils. So I'm not talking about like petroleum jelly or Vaseline or anything like that. I'm talking about coconut oil, like vitamin E oil, olive oil. So these can be used as lubricants and as moisturizers. They are quite long-lasting. They can be organic. The big piece is they are not compatible with latex or polyisoprene. So many barrier methods of contraception cannot be used with oil-based lubricants. But many people love them. I have had many people tell me and swear by coconut oil as a lubricant. So something to think about if you're interested, and if you've got your KY jelly that you're just getting so fed up with, there are other options out there for you. Okay. So pelvic floor physio. This is another one of the ones where I often have people tell me, like, I've never heard of that before. If you haven't heard of this, you are not alone. But just like we can get physio for our other muscles and parts of our body, we can get physio for the muscles on our pelvic floor. So in the pelvis, there is sort of almost like a hammock of muscles at the base. And those muscles can be too loose or weak. They can be hypotonic, or they can be too tight. So they can be hypertonic. And we can experience challenges like incontinence or pelvic pain. And these are things we can talk to a pelvic floor physio about. And they will actually do a hands-on assessment and check those pelvic muscles and give us an idea of what's going on. They might teach exercises to strengthen or to relax the muscles. They might suggest vibration or massage, or they might recommend a process like dilation and actually walk us through that. So that can be a really good resource for dilation. Of course, physiotherapy can be quite expensive, especially if we don't have benefits. But if you're interested, there are a number of clinics. I don't know across Canada. I know here in Vancouver, and I imagine elsewhere, that offer those sliding scale. And one thing they do talk about is vibration and massage. And these might be things we also engage in on our own for pleasure or for rehabilitation, for lots of reasons. So whether it's on our genitals or other areas of our body, wherever we bring vibration and changing pressures, we're going to engage blood flow. And whenever we increase blood flow, we're going to support healing. So vibration and massage can change stimulation. If our sensation in different areas has decreased, which is really common, we might be able to increase blood flow and perhaps increase sensation, but it also might just increase the intensity of stimulation, so we feel things differently. So we can play around with that and see if it works for us, if it's interesting for us. Yeah, so I share that. Okay, and as promised, I mentioned at some point we would get to desire, and this is a really big one. This is a huge one. I will say, I think this is probably what I get asked about the most of everything, because it's so common, related to a lot of things. It might be related to an illness experience, but we might also notice desire goes up and down in our lives and other things. Perhaps you've noticed when you've been in a lot of stress, it changes, it goes up and down, or any other emotional experiences. So it's really common to be grappling with this. And so as you can see on the slide there, it can happen to anyone after any type of tumor diagnosis, cancer, or treatment. It might be related to treatment impacts. So for example, if somebody's on androgen deprivation therapy, like for common with prostate cancer, that might have really big impacts on desire. It might be related to the symptoms of treatment. So if sexual activity is hurting because of vaginal dryness, it's not surprising that our desire for this kind of activity is going to decrease. It's not surprising that we don't have a desire for something that doesn't feel good for us. It also might be related to our emotional or psychological experience. So if we're feeling distressed, distracted, it might be harder to notice or to cultivate desire. So this is a really good point too for me to note the difference between desire and arousal. So these are two different things, right? I often get asked or joked about, if only there was a desire pill, and often people say for women, if only there was a Viagra for women. And humorously, there actually is a drug called flibanseran, which I think is very funny because that has to be like the least sexy name that anyone could come up with for a drug, like flibanseran.
Yeah, that's a terrible name.
Yeah, it's bad. It's bad.
Yeah.
But it wasn't very effective. Like it didn't add much for people, and it came with a lot of side effects. But the piece to notice is that even Viagra, it's not a desire drug, it's an arousal drug. It creates capacity to become aroused, but it doesn't make people desire that kind of contact. So we don't actually have a medication that impacts desire. And it's probably because desire is really complicated. You know, there's not like a particular piece that flows through our body and we go, oh, that's what desire is. Like there's that little molecule that's desire. It's a lot of different things. So we don't, though we don't have a medication that directly impacts desire, we can intervene on those changes and engage differently. So this is the linear sexual response cycle. This, you might notice, perhaps some of you have heard of Masters and Johnson. I think there's actually like a little web mini series out these days. But Masters and Johnson were researchers back in the late 50s and 60s who actually brought people into their lab, individuals and partners, and had them engage in sexual activity while they were hooked up to a bunch of monitors. And they actually came up with what they called the sexual response cycle, which isn't quite what's on the board. That's sort of a mesh. But what they had was, okay, so what happens is people get aroused and we go up like this, and then they hit a plateau, and then there's an orgasm, and then there's a resolution. And it was like, oh, we figured out sex, look at us go. Which is great. I'm so grateful for that research because it really started things off. It was so important, but it's not the whole story. You know, some people see that trajectory and they go, yeah, that is what it looks like for me. But many people look at it and they're like, yeah, that's not how that goes for me. That's not what that looks like. Maybe there's multiple orgasms. Maybe there's no orgasms. Maybe the arousal isn't that straight up line. So it can look a lot of different ways for different people. And then later, some more research came around from a woman named Helen Kaplan who talked about desire and said, hey, we're missing the desire part of things. And she put it right up front and said, so how it actually goes is there's desire, and then there's arousal, and then there's orgasm, and then there's resolution. And again, you know, some people would have looked at that and went, yeah, there we go, that's me. But a bunch of other people are going to say, no, that's still not what it looks like for me. That's still not how it goes. Which brings us to this idea of spontaneous versus responsive desire. So spontaneous desire is kind of what's on the screen right now. It's that idea that desire just pops up out of the blue. There it is, ready to go. I want sexual activity. And that's true for some people. Some people will really resonate with that. But a lot of people will say that's not what it looks like for me. And perhaps what they experience is what we would call responsive desire, where it doesn't just pop up out of the blue. Maybe it comes up later. Maybe it comes up after we receive touch from a partner or after we see some kind of erotic stimuli, like it comes up in response to something. So it can look differently for different people, which is why I'm going to share for you a bit of a different model that I think can be a lot more helpful as we think about how do I want to engage with desire differently, and is there anything I can do about these changes I'm experiencing? So this is from a researcher at UBC, Rosemary Basson, Dr. Rosemary Basson, who came up with this more circular sexual response cycle. And I know you're probably looking like, oh my gosh, I'm back in like school looking at diagrams. I'm gonna walk through it slowly and don't feel like you need to memorize this at all. But basically what she said was we all start off from a place of having a reason for sex, having a reason for our sexual encounters. And that part often gets left out, right? So there might be reasons like I wanna be close, I wanna be connected, I wanna feel pleasure. But some of the reasons that we don't talk about as much are we might be trying to avoid something negative. So, you know, I feel like I'm a bad partner if I don't. I feel guilty. So there's lots of reasons that we might engage in sexual activity. But once we have a reason and we are willing to either find or be receptive to sexual stimuli, we start to move around this cycle. And the next one is the sexual stimuli and the context. So that's what's actually happening. You know, what are the stimuli? Am I getting a back rub? Is there something on a screen? And what's the context? Like, do I have privacy? Do I have a door that locks? Are there 5-year-olds running around in the other room? Like, what context am I in? And so when we are in that context, in that sexual stimuli, we might then reach a point of arousal at some point, but that gets impacted by biological factors and psychological factors. So like biological factors could be many things. Are we tired? Are we nauseous? What's going on in our bodies? And psychological factors, like, am I distracted? Am I anxious about something that's happening tomorrow? Am I thinking about what I'm going to make for dinner? Like, what might get in the way of actually reaching that point of arousal? But if we do reach that point of arousal, Perhaps we notice that arousal, we feel it, and then we might hit a point of arousal and responsive desire. So you'll see in this model, this is the first time we see desire. So it's way around. A lot of stuff has happened before we've gotten here. And I think the really important part of this model, the part that I really appreciate, is it talks about outcomes, right? So after we've had a sexual interaction, there are outcomes, physically and emotionally. Our body might feel really good. We might feel pain. We might feel emotionally close, or we might feel distant, and that matters. That has an impact on how we engage in the future, right? If we have an experience that's really painful, it's not going to be shocking that that's going to impact our desire to engage again in the future or how we go about it. If it's really positive, that's going to impact too. So spontaneous desire might pop up anywhere around here. We might have that happen for us, but we might not. We might experience responsive desire, or we might experience any of these many things that might get in the way. So this is certainly a more complicated model, but the benefit of this is there are more places to intervene, to think about, what do I want to do differently? So do we want to change the stimuli that happen for us in sexual encounters? Do we want to figure out what works? What do we want in the room? What do we want going on? Can I find a different context? Do I need to plan for a time when no one else is in the house, or plan for a time when maybe I'm doing better in the morning or in the evening, whatever that might be? Is there something I can do to intervene on those biological or those psychological factors? Maybe there's a time of the day where my body feels better, where I feel like I'm doing better. Or maybe if I'm someone who's getting really distracted, and there's so many things going on, as many of us have, and I'm constantly making to-do lists in my mind, maybe I need to work on mindfulness, about bringing myself back to this present moment, to this encounter. And I'll use this as a quick plug for our mindfulness workshops. If you are someone who can access our services, we have quite a few of these. And if you're not, there's no shortage of mindfulness programs out there. Gosh, like they're everywhere if we choose to access them. So it can be a wonderful thing to engage with. And I also have a book at the end in the resources that I'm going to draw your attention to. But there are lots of ways we can intervene here. So it might be worth thinking, in my version of this cycle, where am I getting held up? What's getting in my way? And is there something I want to shift about that? And if you are someone who's experiencing pain with sexual interactions, then my recommendation would be to stop what hurts, because we don't want to create associations, right? We don't want to start associating our sexual activity with pain, because then we come to expect pain, and that can cause challenges. So is there another kind of activity that you can do that feels good? Like, what feels good is the bottom line of that question.
If I can add too, Tess, a lot
Yeah.
is also identity, right? Like
Yeah.
they've lost, some identity through treatment or through diagnosis, and they're just not feeling themselves, right?
Yeah.
So it's really hard to have that connection with their partner when they're not even feeling like themselves, and how to overcome that. Yeah, I
Yeah.
love this model, and having these, what it really kind of explains, what is holding us up, and having this is really, really helpful.
Yeah, that's a really wonderful point too, Todd. Certainly, that probably goes right there in those psychological factors, right? If I don't
Absolutely.
feel like me,
Yeah.
it's really hard to engage. Yeah, and that you're actually giving me just a wonderful transition to my next slide.
Nice.
Well, the next few, which is really about figuring out what works now, because as Todd said, there's a good chance for many of us that it's different than what worked before, right? My identity is probably different. Maybe my view of the world is different. Maybe my experience of my relationship is different. So this is a big part, I think, of where we go from here, is expanding our definition of sex. So some of us might have a goal-oriented view of sex, and this is it's a very heteronormative view of sex. This is like the story we get told in society, that sex is linear, that it follows a sexual script, and usually that script is, maybe there's some kissing or some touch, maybe there's some foreplay, then there's penetration, and there's orgasm. Again, very heteronormative view of sexual activity, right? And very linear. And it's defined by the activities we're doing, the type of activities, and the outcome, whether or not there's orgasm. And the challenge with this way of looking at things, right, is if penetration doesn't feel good, or if we're having a hard time reaching orgasm, then suddenly we failed at sex, like we did it wrong. But the other thing we can do, other than trying to change how we achieve those things, is look at sex in a different way. Like, can we broaden the way we look at this? So rather than a goal-oriented view, perhaps we take a pleasure-oriented view. So it doesn't have to be linear. And it's not defined by the activities or the outcomes. It's defined by how we experience it. So as long as we are experiencing pleasure, we have successfully achieved this sexual interaction, right? It's defined purely by an experience of pleasure, whatever that means for you. That might mean something very different for you. And it requires open communication, right? Because we no longer have this unspoken script about what we are and aren't going to do. We have to talk about what we want to do. And this is where Todd's point comes really important in the next few slides. Is in order to talk about what we want, it takes a bit of exploration to figure out what exactly that is. So this is a quote by Dr. Emily Nagoski, who you might be familiar with. Maybe some of you have read the book Come As You Are, which is quite a big book these days. If you haven't, highly recommend it. It's wonderful. There's a new and revised version that recently came out. And this is actually a quote from an audio clip where she's talking about the revisions that she added to her book. And she says, "Pleasure is the measure. What matters is whether you like the sex you are having. And when you put pleasure at the center of your definition of sexual well-being, all the other pieces of sexual well-being cascade into place." I found when I heard that, I found it quite a powerful quote that, you know, what we're focusing on is pleasure and then work our way out from there.
Yeah, it certainly redefines what that experience is, right? Like, as you said before, Tess, you know, if you didn't achieve orgasm, you failed. Well, that's not right. And this is such a much more encompassing and I think a more meaningful way of defining what sex is.
Yeah, I think so too. And I think we can expand it beyond our sexual interactions too, that we can think about our relationships that way
Oh
too,
yeah.
that, you know, it's not about being a certain way. It's about what does connection mean to you? What does intimacy mean to you? Rather than, you know, trying to achieve outcomes or things that we think are what that means, or perhaps what they were in the past. So it's about exploration now and figuring out what feels good.
Yeah.
Which I unintentionally, I didn't actually mean to, but I just said the title of my next slide, so that worked out well. But yeah, figuring out what feels good, coming from that pleasure-oriented approach. This requires a bit of exploration for most of us. Like, many of us perhaps have never really given ourselves the space or the permission to do this. And maybe we, even if we have, it's changed now and we're going through that process again in the wake of a tumor diagnosis, an experience of treatment. And it often requires exploration, and that might be on our own, and it might be with a partner or with partners. If it's particularly around sexual activity and pleasure, one thing we might try is something called sensate focus. And this is kind of the bread and butter of sex therapy, but it's essentially a practice that can be done individually with our own body or with a partner, where we explore sensation and touch. So if we're doing it with a partner, we would take turns giving and receiving touch, and you'd start off with genitals, breasts, off of the table, like not areas you touch. You're exploring the rest of the body. And you're just giving touch and noticing for the person receiving the touch, what feels good? What feels good? What do I like? What's maybe uncomfortable? And then taking turns doing that. And over time, the person who's facilitating this with you would perhaps help you to know when to reintroduce those other areas of the body or different activities and walk you through this. So that might be one process that's helpful for figuring this out if you're wanting to do that, about what feels good. And this is just some language. It can take time to figure out and practice what language works for us while we are figuring this out. If we are in a relationship, these may not be conversations we've had, and they may not be easy. Or if we're not in a relationship and we're thinking about having a sexual or a romantic relationship, it can be scary to imagine having these conversations with a new person. They can be quite vulnerable. So thinking about what language we want to use can be helpful. And it might be something you even do with a counselor, a therapist, or a support person, just to get some help as you do figure it out. But what feels good? Those statements like, I like, it feels good when, I want, or inquiring, what feels good for you now? And sometimes we don't know the answer to that. So it might be something along the lines of, I don't know what feels good for me right now. Are you willing to explore that with me? So those different conversations can be helpful, and finding the words that feel like a fit for you can make it feel more authentic and genuine and meaningful for you. And exploring closeness and intimacy. So I feel intimate with you when, I feel connected with you when do you feel connected with me? I feel appreciation for you when, or I feel appreciated when. And having those conversations can be helpful for building intimacy, closeness, pleasure where we are right now in our lives, and letting people know that that might be different than it was a week, a month, a year ago. Yeah, so it's a lot of communicating. So we might want to think about boundaries and requests. So what are the boundaries we want to set about what is and what is not wanted and what is on the table? What I mean by that is it's almost like we're making a table, we're setting a menu. It's like we're deciding with our partner what we're both open to for each interaction. So for tonight, this is what's on the menu and this is what's off the menu. This is what's not available. And this menu might be fluid. So it might change for every interaction, which means we might have to have this conversation for every interaction about what we're open to, what we are wanting, what we're not open to. And of course, this is going to be different for each of us, and perhaps different from the people we're engaging in interactions with, which is why the communication piece is so important. And because these are hard conversations to have and practice, again, it can be helpful to get support with it. So maybe we want to talk to a counselor on our own or with a partner, engage in sexual health therapy or sensate focus. And we're coming really close to the end here, I promise, because I just know I've been talking at you straight for a long time, but a couple more. So a little bit more around what communicating might look like. Again, the language of what this might actually look like. So setting boundaries, what I'm open to, what I'm not open to, what is off the table right now is asking other people, what are you open to? What are you wanting? And inviting and requesting contact. That can be hard for a lot of us to do. It can be vulnerable, but it can be helpful to say, right now, I would like touch, I would like intimacy, I would like closeness. And sometimes it's both. It's right now, I would like this, and I don't want this. How is that for you? And a quick note on declining contact, because I've had many people tell to me over time that it's really hard for them to set boundaries, especially when a partner makes a request. So declining contact might be using words like, I hear that you would like to, and I appreciate you sharing that want. Right now, I'm not open to that. And another really important piece that I think can be so helpful, tell your partners what declining contact does and does not mean for you. So I'm declining this contact because that type of activity doesn't feel good for me right now. When I decline these contacts, it does not mean that I don't care about you, that I don't love you, that I don't want to be close with you. So letting them know that that's not what declining means for you. This is what's going on for you. And when possible, have these conversations ahead of time. You know, it can be hard to have them right as we're in the throes of things, like, oh, wait, stop. It can be more awkward. So if we set a time ahead of time to actually talk through this, that can be really helpful. Maybe we even schedule these times to talk when we have lots of time or privacy or without interruptions. And again, might be helpful to get some support with these conversations if you imagine they might be difficult ones. Okay. All right, last couple slides here. So talking to your healthcare team, where do you go from here? I've just given you a ton of information. Maybe some of it seems clear to you. Maybe you have a bajillion more questions than you even started with. You might consider talking with your healthcare team. So this is just a list of some questions you might ask. It's from an information booklet that is at the end. Again, pretty cancer specific, but it has some good questions that I think work for anyone, regardless of diagnosis. But basically, what might affect my sexual health? What can I do about it? Lots of questions like that might be helpful to ask. So consider what you might want to write down and bring to your next appointments if that's applicable for you. Okay. And resources. So this is a small subset of what could be a whole book full of resources, because there's a lot of stuff out there worth exploring. I've mentioned a few of these books. Come As You Are by Dr. Emily Nagoski is quite directed at cis women, but I do think has helpful information for everyone. Better Sex Through Mindfulness is by Dr. Lori Brotto, who's a researcher here in Vancouver. Again, quite directed towards women, but helpful information, again, I think, for everyone. Self-Compassion is a book by Dr. Kristen Neff, a psychologist who focuses on self-compassion. And I think self-compassion is such an important piece of going through this, about being kind to ourselves. And also, if we're somebody who's struggling with some changes in body image or has always struggled with body image, self-compassion can be a really important piece. So I think I recommend that book for everyone. There's some books specific to cancer and sexuality by Dr. Ann Katz, another researcher there that you can see, as well as that Canadian Cancer Society booklet. The websites below. The self-compassion website is Dr. Kristen Neff's website. The second link there, the myhealth.alberta.ca, cancer and sexuality. If you Google something around this, you're going to get the website to the Alberta Health Services Oncology Sexuality site, and it has great information. This is actually where I previously worked, which is why I know so much about this, but they have a number of booklets for different bodies. There's one for bodies with vulvas, one for bodies with penises, that go through a ton of that physiological information I mentioned at the beginning. So as I said, no need to memorize this. It might be worth looking through those booklets again and seeing which of that information fits for you. So I highly recommend looking through that if you have questions. And the last link there, Queering Cancer, is a wonderful site. Again, quite cancer specific, but for LGBTQ2+ folks looking for support around cancer care. It's not a sexuality specific site like around sexual health, but there is a lot on there around sexual health. And it's also just a wonderful site for folks wanting to connect with others in the LGBTQ2+ community around experiences of cancer. So they have forums, research, all kinds of stuff that's really wonderful. And my last plug is, again, if you're a fit for our services, come talk to us more. If you'd like more workshops, come talk to the counselors or the doctors. We'd be so happy to see you and talk more and to actually see faces. The webinars are wonderful, but I miss seeing everyone's faces. So at this point, that's all of the information, which I know I say all of it as if I haven't been talking at you for a straight hour. But please do let me know if you have any questions. If you want me to go back to another slide and go back through anything, I still have lots of time here to chat if there's anything anyone wants to bring forward.
Yeah, thank you so much, Tess. That was a lot of information and really showing us today, I think, how to be vulnerable and really how to start those conversations, because it can be really hard sometimes, even with the partner that you've been with for a year, 10 years, 12, like who knows? It's just hard because you're really navigating this new identity or this new world, and you know, having these important sexual health and sexual desires, it's a big deal, and we need to talk about this more. So thank you so much for coming today, and thank you all for joining us.